I really like this idea of getting your foot into the door and that collaboration and partnership and creating enough friction between the thought and the person's life so that it doesn't progress to action. Some beautiful thoughts there.
I think with the foot in the door, that's something that needs to be planned well in advance when there's no crisis, when there's, you don't want the foot in the door as in a pestering salesman kind of thing. People will be fighting you.
Yeah.
But it's somebody that has been able to understand and actually wants to be there.
Yeah.
And at that point, there's nowhere else I'd rather be. And to have that permission, it's something that takes time and takes an investment.
Welcome to Protect, Suicide Prevention Training Podcast for healthcare professionals. I'm Manan, consultant psychiatrist, founder, and head of faculty at Progress Guide. Welcome to our listeners on Protect. We today have got Miguel de Seixas. He is a consultant psychiatrist. He's actually head of psychiatry of family medical practice in Vietnam. Miguel used to be one of our star trainees in Cambridge and Peterborough NHS Foundation Trust. And one of my lasting memories of Miguel is one of his consultant interviews, which, by the way, he topped. And a standard question in those consultant interviews was, as a way of like a cool down question before we would end the interview, would be to ask trainees about achievements that they feel proud of. And Miguel pulled out something from the hat which we had never thought of. He mentioned that he was part of a junior national volleyball team from Portugal, and they came fourth in the Junior World Cup. Now, for those of you who follow volleyball, they know that Portugal is not a volleyballing nation. So it was quite an achievement for a country which doesn't play volleyball for them to come forth. And this was something we never knew about. Miguel tells me that was many moons back and a few new operations back, so he can't jump anymore. But Miguel has always been very close to my heart. He, as I said, had been one of our star trainees, then a consultant colleague, worked in Peterborough and Cambridge. And just around the time I was leaving for Australia, I think the end of 2017, he came and told me that he was going off to Vietnam, of all places. Like in my thought bubble, there were the words come again. But he just, I think a change would be good. We always knew Miguel had a bit of a philosopher in him, but who would have known? Someone who is originally from Portugal, trained in the UK, in the NHS, kind of really good Cambridge consultant position, uproots everything and goes off to Vietnam to practice psychiatry. So Miguel, one of the kindest, most compassionate consultant psychiatrists I've known. Thank you so much for taking time out from your busy schedule and joining us today. Welcome.
Thank you. Thank you. And thank you for that, such a kind introduction.
Yeah. So Miguel, how has it been going? Like, it's now been 4 years that you moved to Vietnam. And since then we have had the pandemic, and I understand that you were living in Vietnam, practicing, and then you went back to Europe and then couldn't go back to Vietnam because everything was in lockdown, and you were doing all your psychiatry over telehealth, living in Europe, but working in Vietnam. Now, how has it been going for you?
Well, there's been a pre-pandemic and after pandemic. So I think when I moved to Vietnam, you could feel the energy in the country and in the clinic as well. It was a constant sort of high pace growth place, beautiful place. I think, I don't want to get started on my love letter to Vietnam because it is a special place. I don't think people can be indifferent to life in Vietnam. When the pandemic came, we noticed a significant difference because suddenly there was a lot of uncertainty. Tourism stopped. Vietnam managed the pandemic, the initial stage kept cases very low, but at the expense of basically locking down the country. You couldn't get in unless you were sort of on a repatriation flight, which meant also if you got out, you would struggle to get back in. So at one point in 2020, towards the end of 2020, we had to be in Europe with a plan to return 2021, but then we had the what was called at the time the UK variant, and this was before vaccines. So the attitude was very risk averse. We not being able to fly while the UK variant was going on, and later in the year when things improved in Europe, they were really terrible in Vietnam. They had a very strict lockdown, and at that point it made no sense to travel with family. So we ended up just going to Vietnam in January. Was there the last 3 months, just returned recently to Europe for
January of 2022.
January 2022. And I think July I'll be back in Vietnam.
So today, right now, you are in Porto and you have just finished a clinic of seeing patients in Vietnam through telehealth. And I think you kind of in a couple of hours, again, you will be seeing patients again in Vietnam from Porto.
Yes.
So the world's become a much smaller place, isn't it?
And in Vietnam, even in Vietnam, when I'm there in Saigon, we do see patients from Hanoi, patients from Da Nang, from other cities. It's quite a big country. So since the start of the pandemic, I think the pandemic was almost the reason to introduce telemedicine. And then we realized actually we can reach so many people that wouldn't be able to travel to Saigon, Ho Chi Minh City, where I'm usually based.
Yeah. Amazing. Sometimes necessity is the mother of invention, but then it opens up all sorts of new avenues. Because originally when I wanted to interview you for the podcast, really in my mind, I was thinking of people that I know who can provide a different perspective, because often one of the questions I'm asked in trainings and in presentations internationally is regarding cultural contextualization of Protect. Like we're doing a lot of work in Peru at the moment where Protect is being translated into Spanish and contextualizing the entire suicide prevention framework to the sociocultural backdrop of a low or middle income country. So that's why I wanted to kind of interview you, because you had gone from Cambridge, working there as a consultant, to Vietnam, and to get a sense of the difference and how we could, what kind of changes do we make as we kind of contextualize the training to different parts of the world. But then in our catch up the other day, when we were thinking through the things we can talk about, the whole thing around telehealth came up. And I started thinking that is another amount of contextualization we need to do around suicide prevention programs. And so I thought there are two really important tracks to talk with. Which one shall we go with first? Kind of the...
Well, I would follow a sort of a chronological order, because the contrast is actually bigger when you compare, say, a service like we had in Cambridge and when I get to Vietnam. In my first month, I could clearly see that we could not operate the same way as we did in Cambridge, because we didn't have the resources, we didn't have the staffing. Patient group is completely different. You don't have the luxuries of strict boundaries of your involvement when you refer to a different team and to work. So you need to be constantly finding ways to get yourself involved in finding a solution to the problems that are brought to you. So that was very obvious at the beginning. I remember I had to dig sort of medical ethics books, because you feel I have to do some piece of work that I don't feel so comfortable with this. But the alternative, it's even worse. So what do? Do I sort of remove myself from the issue, keep my hands clean, or do I get involved? We try to find a way that is useful to improve the situation of the person that you're seeing.
So person-centered care takes a very different form based on the context of where you're working.
Absolutely. The resources you have available, that is crucial. And in psychiatry, in my experience, which was always very mainstream, in a very good place with excellent people, I'd never had to face that. So it could be quite a lonely place at the beginning, and you're sort of the new psychiatrist, so everything in this field would come to me, and I had to adjust my practice, and that was obvious from very early on.
But the foundations of good psychiatric practice in terms of virtually the kindness and compassion that you show, and I've always thought of you as one of the poster boys for relational safety, being able to form really good relationships with patients. That is the same across the world?
I think so. I see no difference really in that aspect. Now you have, that's the fundament of the way I see psychiatrists, the work of a psychiatrist. And then there are other aspects that you need to adapt and adjust. And patient group that we have in our clinic is extremely varied. We see people pretty much from all over the world. There will be only a handful of countries that I've not met people from. But as long as you have the interest, and as long as you don't forget that your first and most important role is to try to connect with the person you have with you. People that are seeing a psychiatrist, they're doing it for a reason, and usually a good reason. And there's no such thing as an inappropriate consultation or referral, which was sort of something we struggled a bit in the UK, whether it was appropriate or not. I think that it's always appropriate. And my role is to try to get in touch with the pain that people that see me have, and allow a bit of that pain to get in touch with me as well. And that doesn't change wherever the person is from. How you get there might have to be adjusted. But not as much as I thought, as I thought I needed to adjust it. So actually, people are people, wherever they're from. There's, of course, cultural differences in communication style, and you need to be observant of that, and you need to learn the culture and learn how to connect. But it's still the same fundament of getting in touch with the pain that the person is bringing you, or the discomfort in some cases.
I think that's beautiful. That's beautiful, Miguel. And I think that's a gold nugget in there, that kind of not just you getting in touch with the pain, but allowing the pain to get in touch with you, and you as a healthcare professional going into that sphere. And what you said there was how you get to that pain, the process might be different. So the journey might look different, but the destination is the same. In order to connect with the person is to grapple with the pain that they're struggling with. And this business of allowing the pain to get to you. And if you've been in the NHS, where you've done your entire training and your consultant practice there as well, you were telling me that some of the severity of presentation, particularly of people who haven't been treated for a long period of time or haven't had the right treatment, might be extremely severe for someone who has worked in a protected setting like one in Cambridge. Was it quite an eye-opener for you?
Well, when I was in Cambridge, there was something that started bothering me more and more as I progressed in my career. And I think we tried to address it with things like PRISM. That was towards the end of our time there, which was this. I would very often see somebody in my clinic. I was working in the community at that point, and would hear the story, would assess the patient, and I would wish that I wished I had seen that person 6 months earlier. The patient wished they would have seen me 6 months earlier. The referrer wanted me to have seen that person 6 months earlier, and yet we didn't. We were just meeting at that point. And that started to bother me more and more. And I think the idea was to try to have early intervention, reach out to people more, and don't wait so much to get help. In Vietnam, we've been able to do that.
Okay.
And I think being in the private sector, there's no referrer very often. Sometimes there is, but we need to find ways to be responsive quickly. The patient group we see, they tend to be people who are career people or in education, and that's an important part of their life. Sometimes the reason that took them so far away. And it's important that people remain functional. So early intervention becomes more important. We don't have the same systems for acute care as we would have in Cambridge. I don't have the luxury of crisis teams or inpatient units with fully staffed, well-trained people. And this is not just for psychiatry, by the way, but the onus of remaining well and people looking after themselves and recognizing problems early and knowing what to do about them and having partnerships with, that can mean a relative, that can mean another professional, that can mean the clinic as an institution or the professional individually or a psychiatrist. It becomes much, much more important because the cost of an acute presentation is much higher because we have less to hold it. And actually, literally, the cost will be higher being in the private sector. Sometimes it will be too high that the person cannot manage if they don't have an insurance policy that covers it. So there's a much greater importance of remaining well. Mapping your mental health as well as your physical health. It's not exclusive to psychiatry. Other colleagues have the same problem. But having almost a map of where you are with your mental health, your symptoms, and sometimes even upstream from outright symptoms. How you're managing your daily pressures and your stressors and the problem in your relationship or work, etc. So I'd encourage in Vietnam people to reach out. And if sometimes many people I see, they don't have a psychiatric diagnosis. And sometimes they're lonely in face of huge pressures and they want to think it through. And they want to know, what should I pay attention to? When should I worry? So, and I think that's an important role that we can do as mental health professionals, trying to prevent morbidity, if I use this lingo, but then prevent things from getting worse through something I remember you telling me, reducing the risk by treating the condition.
Yeah. And I think it's kind of the parallel with physical health is actually quite a good metaphor because, if someone was getting atherosclerosis of their cardiac vessels, we wouldn't kind of just wait for another 6 months for the heart to for those vessels to kind of get blocked and for the person to get heart attack, right? We will, at the early onset of angina, we will kind of act and do something. And in my mind, a suicidal crisis or a psychotic break from reality or a manic relapse, they are like a stroke or a heart attack or a myocardial infarction. So the case for early intervention, early recognition, early intervention, proactive care, reaching out, and as a community psychiatrist is absolutely pivotal because that's what we would do in the rest of medicine. So thinking about this journey that you have been on, and I think you were talking about people continue to function in their lives, personal lives, in their workplaces. And when you have traveled overseas, it is really important for them to keep on functioning in that space. And I think one of the great levelers has been COVID-19. What it showed us was that the things that bother people with mental health challenges are the same things that bother staff who are working in mental health, right? So contracting COVID at work, keeping your family safe, worried about your employment, worried about your own health. You know, it's the same things that matter to you, that matter to me. You know, it's there's this beautiful picture from Mental Health Foundation where they have got these different boats, people on different boats, but they're all in the same storm. So different boats going through the same storm. And it kind of showed us that the things that matter to you or me, whether we are a health professional delivering care or someone with mental health challenges receiving care, are exactly the same things. And I wondered, in your kind of experience of going through the pandemic, having to work through telehealth, did you find similarities in what you might have felt as a fellow human being traveling through this and the people that you were supporting in Vietnam over telehealth or even face-to-face in the early days?
Yeah, I think so, but not exclusively during the pandemic. Mm-hmm. You know, so when I moved to Vietnam as an expert, you're subjected to all the same pressures of immigration and paperwork, mm-hmm. and as the lifestyle, suddenly you are away from your friends and your family. You bond with people who are in the same circumstances in different fields of work, but still, that with their families away from their places of origin, trying to adapt and have to make the best of. So there is a greater identification. So my life and the pressures in my life were much more similar to the pressures of people that I see in my clinics in Vietnam than they were sometimes in the clinics that I saw in Cambridge, for example. Mm-hmm. There would be, say, examples like the work with the Access Clinic, which was under my patch. And Access Clinic is a clinic, a GP service for homeless population. I would do a clinic there in Cambridge. We would sometimes do outreach and see people wherever they were, even in churches, for example. The crossover between that person's life and my life was much less than what happened in Vietnam. And that makes you feel much more closer to the problem, the social aspects of the problem touch you more closely. When the pandemic came, one big issue that I think to me made a difference, and to many other people I know made a big difference, is that suddenly part of the equation that got you to a place like Vietnam is that if there is a problem, if there is a health crisis, if there's a family issue, you hop on a plane and you go back to your country. And that is a very important part of the decision to move to a place so far away. And suddenly that possibility disappears. So the equation changes. So you're now far away in a country that I love, but I don't have the possibility of going home at a short notice if there's a health problem or some other kind of problem in the family. And that was a big stressful factor for expats. For the Vietnamese, the patients that I see, there was a lot of people with the uncertainty. So I think that part of the world has had problems with pandemics before. I think at the beginning, from the very beginning, I think the Vietnamese population was more worried from sort of ground up. I remember at the very beginning of the pandemic, a lovely lady that helped us at home called Yao got home with 2 big bottles of vitamins, and saying, oh, there's this, we hear about this illness in China and it might come here. So you foreigners probably don't understand the news. So I brought you these so that you take the vitamins, be ready, be in good health, etc. People took it very seriously from the beginning. They felt the economic impact. The country closes down, tourism disappears. So that pressure that was felt by the Vietnamese patients clearly. Whereas the expats was the sense of being imprisoned, so to speak, with all the freedom. People could go out, could travel, etc., except leave the country.
Yeah.
And that makes a big difference.
Yeah, it's amazing how someone that you are supposed to be looking after actually is worried about your well-being and is looking after you with vitamins.
Yeah.
I remember like in the early days, we were kind of asking our patients, what would you like to be doing when the pandemic is over? And we were getting remarkable answers, remarkable in their simplicity. So they would be saying things like, oh, I would just like to go to Woolies. Woolies is like the Tesco's, it's the supermarket. I'd like to go to Woolies and be able to hold a trolley without worrying about what is it I'm contracting. I would like to go to a park and be able to read a book without the police telling me you shouldn't be out. So they were very simple. I would like to go, all the nursing homes got locked down. I'd like to be able to go and see my parents in the nursing home and give my dad the biggest hug possible. In fact, I had a patient who was extremely high. This was on one of my older adult wards. And you could see she wanted to hug people and kiss people. And like at the end of the consultation, she got up and I knew there was a big hug coming my way. And I said, but she could sense my anxiety. And she just stopped herself. And then she took a step back and said, "Doctor, stay well and stay safe." That moment for me captured that whole kind of premise that we are 2 human beings doing a journey, very similar journey. I'm looking after them and they are looking out for me. That was a really kind of touching moment for me, someone who is highly managing to contain their excitement. That was, I think, quite a revelation for me to see that the things that matter to me are the same things that matter to people living with mental health challenges. It's something, it shouldn't take a pandemic to open our eyes in that way. But I feel that it's been a great leveler. Like I was very worried about my parents who are in India and I couldn't go and visit them. But I was very worried because we had lost relatives to COVID, they're elderly, late 70s, early 80s. And that was always on my mind. And some of the conversations I would have with my patients, they would have very similar worries, very similar concerns about their elderly parents. And there was a connection that I formed with patients, which was not the usual relational safety that we talk about, the usual connection where we kind of try and connect with the pain. There was something much more human and humane about the whole thing. We were just connecting over common ground in a way. And of course, we were talking about the person's mental health challenges, but there was a different kind of connection with a lot less power differential, I found, because we were worrying about very similar things. So tell me, Miguel, one of the things that I'm really interested in is during a telehealth session, if you run into a situation where someone is highly distressed or you are actually worried about someone's safety, what is your response? And is your response quite similar to how it would be if you were seeing them in face-to-face, or is it quite different? Are there particular things that you tend to watch out for? Are there particular safeguards that are built into the practice? Because you are in Porto, seeing patients in Vietnam. So I don't know what the time difference is. So it's
6 hours.
6 hours. So it's 10 o'clock here. So it would be 1 p.m. in, is it 1 p.m. in Porto or 2 p.m. in Porto?
I hope it's 1.
It's 1. Okay. It's 1 p.m. in Porto. And then, so it would be around 7 p.m. right? So it would be 7 p.m. in Vietnam, in Saigon. So, and you're supposed to see someone in an hour's time or 45 minutes time. So it would be quarter to 8. And if, of course, it's your afternoon, their evening, 2 different time zones. If you found someone getting distressed, how would you manage that scenario?
I would need help. So that when that happens, and the same, we've had this situations such as this in Saigon, when especially during the pandemic, people from the other side of town would prefer to have a teleconsultation. Usually we need allies. And those alliances, unless it's the first consultation, the allies, that have been prepared somewhat. There'll be parents and husbands and wives and friends, etc. That we could tap into. I like that the patients have a sort of an adaptation of the well-being plan that we used in the community, which would list the relevant professionals and relevant people in terms of relapse prevention and in crisis. Mm-hmm. So we would try to have a significant other to help and to convey the person to the clinic physically. And we're lucky to have a group of very dedicated doctors and very empathetic nurses. And we would organize an inpatient stay, similar to sort of what would be the assessment unit in our previous lives, so that it would be a point of manage the risk in the acute setting, do an extended assessment, find an alternative that is sustainable for further treatment. So at that point, my priority is getting people safely to the clinic. And of course, I'm here. Sometimes I'm in Vietnam. Sometimes, I've been in England while working. But I'm always in contact with my team. I'm always supported. I've got an excellent, I don't know what to call her. There's so many things, Miss Bing, that is my sort of eyes and ears on the ground and helps me with coordination, makes sure that I'm not wasting time trying to find the right person. My colleagues have been spectacular. Every time that there is something happening, they're there. And we've managed to do short-term admissions with a medical input, a nursing input, and psychiatric input. In these admissions, the psychiatrist consults. So there is a medical, usually a physician that is responsible for the organization and practicalities, and then we'll arrange a treatment plan. Now, this presupposes that there's somebody that is willing to engage and willing to accept help of some kind. Or I should say, willing to explore other alternatives to their plan. So being able to have those conversations. I worry much more about the people that I don't get to see, because we don't have an outreach system. We don't have a home visit crisis team, etc. It's a private clinic, so people would pay for their appointments, and that can be a barrier. I always try to say, call, email, we'll figure something out. Just come and we'll deal with all of those things later. So trying to remove as many barriers as possible, no friction to come forward. But I would use the physical space of the clinic, my colleagues, as I would if I'm seeing somebody face to face, and I would organize the admission there and then. We don't have to worry so much about sort of whether you have beds or if you need to discharge somebody, because we don't. It's a relatively rare event in this setting.
So I guess the principles of care are very similar. If it's face-to-face, you are depending on a team to support you with the admission. Similarly, if it's telehealth, you're depending on a team to support you with the admission process. Well, it is important to have your allies on the ground, as you said, that if you need it, that's very similar. Also, proactively thinking through safety plans and relapse prevention plans or wellness plans in advance, so that if that situation does arise in the midst of a consultation, then, or in between consultations, the patient knows where to get help, because you may not be available. You may be asleep. It may be the middle of the night for you.
I would encourage people to still, my colleagues to still contact me if it was at night. I think the missing link here is how to identify when the risk management plan actually becomes relevant.
Yeah.
And there's so many variables, so many aspects of life that can just, activate risk without being properly, and it can't be planned. To some degree, that's the unexpected. So what can we predict in terms of the factors that would increase the risk that would make the last risk assessment redundant? And I think you can't really predict for everything, but you can predict for the next action. So if this happens, then come here. And it might be, then take this sort of emergency medication so that you're not so agitated, or that you can sleep, or you get hold of your parent and ask them to be with you until you can come and see me. So trying to predict the presence of such an event and then hope it never happens.
Yeah. I think that's really, really important. So in our training, we talk about SAFE as a protocol. S stands for scenario planning. A is access to means. F is family, friends, and follow-up. And E is an emergency plan. So in effect, what you did over there was you very nicely outlined the content of scenario planning. And you used two phrases. One is what if? What if this happens? What if that happens? So being able to look into the future, and you may not be able to prevent them from happening, but actually thinking about that sometimes might be protective, because then you're on the lookout for that. And then the other statement you used was the other scenario planning statement we use, which is if this happens, then do this. If that happens, then do that, which is proactively thinking through. And that's one of the big shifts in our thinking that we are trying to bring about through Protect, is moving from a mindset of prediction to a mindset of prevention, right? Because as you said, there's so many things that can change in such a short window of time that prediction is a fool's errand. Risk is so dynamic. There are so many factors that can influence risk, and they might be calm and, but there are certain things that you can stop, or at least attempt to stop from happening, which is that mindset of prevention. So let's think about the things that might happen, which might make you do things to harm yourself, or introduce more risk, or make it more unsafe. And what can we do about it? So, we hadn't rehearsed this. You brought up very nicely the key principles of scenario planning, which is what if and if then. If this happens, then what do you do?
And there's another aspect there is if let's say you've done that work, and then there is an escalation of risk, and the person just even remembers that previous conversation, or goes and gets the relapse prevention plan, or immediately you are there. The mental health professional is there to some degree with the person, because you've anticipated and you've inserted yourself in that crisis period. And that can be the difference between I'm alone with this, or actually I'm physically alone here, but I'm not alone. There are options. Suicide is a rare event, but it does happen. This doesn't mean that you'll prevent from ever happening. But I think the odds of it being a completed suicide reduced a little bit.
Yeah.
With the type of work that's not that intrusive if it was thought in advance.
Yeah. Yeah.
So you insert yourself in that moment in anticipation.
Yeah, absolutely. And, in most of medicine, we talk about how to close the ideation action divide. Like, so I want to quit smoking, but I continue to smoke, or I want to lose weight, but it's so hard to get to the gym. So the ideation action divide we want to close. Here in suicide prevention, we want to keep that ideation action divide open. And you, or your impression of you, or the conversation you had, that could be the thing in between ideation and action, keeping that divide open. You might not have solved the situation, but the very fact that you had identified with the person and collaboratively thought through that this might happen, and if this happens, what do? You might not have a concrete answer, but the very fact that you have thought it through with someone is healing in its own right. And it kind of makes people think, Dr. Miguel did tell me that this might happen, and I might get very, very low or get very dark thoughts in this situation. So, Miguel, tell me about access to means. Patients are connecting with you over telehealth, on the internet. They are in their home. You are in your, I'm assuming, makeshift office in your home, I guess. And if you find that they say something like, I'm assuming in Vietnam, but you mainly look after the expat community in low middle income countries, agricultural societies, organophosphorus poisoning is a big one. But they might just be saying something like, okay, I've got all these tablets and they have been having some dark thoughts and you are a bit concerned. They say that, I'm going to keep myself safe. Now, if this was a face-to-face meeting, you might have tried to convince them to give up the tablets or return them to a pharmacy. How might you go about a situation like that? Will that be through your team again, or
a relative? I think a big difference, and this is a big difference between Cambridge and Saigon. And my work there is the involvement of relatives. Mm-hmm. Vietnam is a very young country. Mm-hmm. It has a checkered history, to say the least. But there's families often live together 3 generations. Sometimes I hear the sort of a desperate young man or woman that feels that they are struggling to establish their independence from the family, that will get involved in different aspects of their life, and they sometimes resent that. Mm-hmm. But it can be an extremely powerful focus of support. Now, you need to have these conversations with relatives very clearly, explicitly, because there is a limited understanding of mental health in the country. Mm-hmm. There's a huge stigma. So you can't assume that if you mention to a relative, look, I'm concerned, that might not be enough. I think you need to be very specific and say, look, there's these tablets, and please make sure that they are safe. Be with them all the time. You need to be very explicit, because there's still the sense of, we've had it worse. We went through a lot of difficulty and we coped. And people will have ups and downs, but they will cope. Mm-hmm. I think that's changing. That perspective is changing with the younger generation. Yeah. But to work with a generation of parents, I find it very gratifying and learn a lot about the culture, but you need to be very specific in the advice that you give. Yeah. Even with our staff, our nursing staff, you need to be specific in what you request. So,
sorry, Miguel, I think it's a really important point that you've made, and I don't want my listeners to lose that point, is awareness of the mental health literacy of the family and the importance of being explicit. So, because it's so easy for us to assume that they know things and that they they would be able to act from common sense. And yes, they may be, but it is really important that, because people might not have been exposed to that level of severity of an illness, or there may be a degree of denial, or it may be completely unconscious that, as you said, in a place like Vietnam and the hardships they have had, oh, we've gone through that. What is this compared to what we went through in the 70s and 80s and 90s? So people might be standing intergenerationally on very different hills as well and looking at the same problem in very different ways. The person who is severely depressed, for them, the problem might be insurmountable, a hill that they can't climb over. And the person who has gone through some of the atrocities that happened in that country a while back now, which is a distant memory or even this generation haven't been exposed to. So there are two very different perspectives. So the importance of being explicit and keeping that intergenerational gap in mind as well. So I think that's a really important point. Yeah.
This is the access is something we struggle all the time because unfortunately in Vietnam, people can go to a pharmacy and buy medications, even medications that have restrictions elsewhere. For example, benzodiazepines, that's a big issue. You can just go to a pharmacy and buy cheap, high quantities of benzodiazepines. It's a place with very tall buildings, Ho Chi Minh City, with very tall bridges and so on. So you need to recognize access to means it's not going to be that difficult if you haven't been able to sort of put your foot in the door and create enough friction between the thought and the plan to gain some time.
So I think there are two really important points. One is that there are means everywhere and the importance of working collaboratively with the person because, there are tall buildings. I've just started this piece of work, new collaboration with schools in Hong Kong, 22 schools in Hong Kong. And, Hong Kong is one of the places where the most common way people take their life through suicide is jumping off high buildings, right? And there are high buildings everywhere. People are living in those high buildings. In order to overcome that access to means the importance of working collaboratively. I think that's a really important point because if we aren't, then people have access. End of, really. And the other thing, this idea, that's quite a nice metaphor of putting your foot through the door. So there's enough friction so that the thought doesn't progress to the plan. And we talk about this a lot in Access to Means in terms of suicidal urges. They come as waves, but we know that the waves pass, that the waves will subside in time if we can create some time and space in between the thought and the means. If the means are readily available, then they will do something. But and that friction will be those conversations, I'm assuming, that you would have had with the person and their family, which creates time and space or create friction. That's a new way. That's the first time I've heard that. But I really like the sound of that, kind of creating friction for the thought so that the thought can't progress.
Yeah, and I tend to see the actions that we take, including not taking the action, that's a sort of an action in itself or a decision, whether they will increase or reduce the odds of an attempted suicide, rather than being a categorical yes or no, on and off, because that's quite narcissistic that you're thinking that you're going to be doing something that is going to stop somebody. But we have that. I don't know if it's from our training or from our sort of we feel that responsibility.
Yeah.
And that's something I try to step out of.
Yeah.
Because I think it becomes sometimes it's a hindrance to that collaboration.
Yeah.
So I don't want to be. I'm not responsible for you. I'm here to try to help, and I take my job very seriously. So I'm going to try to help very seriously. Yeah. And let's have a go together. Maybe things can change, and that's all I ask.
I think that's a beautiful note to try and pull this all together, because this idea about us as psychiatrists having the humility to understand the limitations of our role. Like, even if you're seeing someone weekly, in a week we have 168 hours, and you're only going to spend 1 hour of that 168 with the person. The person has to manage their safety on their own for the remaining 167. Even if they're on an inpatient ward, if you think about people,
30-minute
observation, what the hell is that? Like, there's enough time to kill yourself 5 times over in 30 minutes if someone really wanted to do it. So that idea about that shared responsibility of a journey together, I'm here to support you in your journey of recovery. I cannot be responsible for your actions, but I will try my utmost and try hardest. But at the end of the day, it is the person who has to take responsibility. But whether we think of it as narcissism or we think of it as responsibility, you kind of use both words. I think it's a really heavy burden to carry. And I feel that if mental health care professionals aren't careful, it's a recipe for burnout. Because like I worked for 10 years in the crisis team. Every day you will see 5 people who are suicidal as a bare minimum. Our caseload of 30, almost 25 of the 30 would be struggling with suicidal thoughts or suicidal plans. And it's very easy to fall into that trap of trying to be responsible. But the reality is that it's almost delusional if you think that you can somehow make it safe. Yes, you can influence it. At the end of the day, it's the person who will manage their safety. So it again goes back to collaboration and partnership working and keeping that ideation action divide open. Because in the mind of the person, there is that continuous battle that's going on between reasons for living and reasons for dying. And our job is to make the reasons for living more and more attractive, capture hope, and kind of show them that there is a way to chip away at the pain or improve your tolerance to it. So, Miguel, I'm aware that you must try and catch some lunch before you start seeing patients again. It's been wonderful chatting to you. Like, there were so many things that you brought together, particularly from a cultural context, your own journey from Cambridge to Saigon, COVID in the midst of all of that, and the idea of you have plenty of freedom to go around the country, but you're trapped inside the country. And that's a strange dilemma. It's quite a unique way to look at that. And we talked about if you're out of the country, then getting back in was quite difficult. So we started talking about some of the nuances of telehealth. And actually, it's different, but it's also quite similar. That's something which is worth thinking about, the similarities of using your team, whether that be in a face-to-face or in a telehealth. You need a team. You need a team who can respond. And then we kind of got into some of the stuff around SAFE. We talked about scenario planning, the what-if scenarios, the if this happens, then what do you do? Doing that proactively. We talked about access to means. We talked about the role of family and friends and being explicit, being aware of the mental health literacy. We talked about managing emergencies. I really like this idea of getting your foot into the door and that collaboration and partnership and creating enough friction between the thought and the person's life so that it doesn't progress to action. Some beautiful thoughts there.
I think with the foot in the door, that's something that needs to be planned well in advance when there's no crisis. When there's, you don't want the foot in the door as in a pestering salesman kind of thing. People will be fighting you.
Yeah.
But it's somebody that has been able to understand and actually wants to be there.
Yeah.
And at that point, there's nowhere else I'd rather be. And to have that permission, it's something that takes time and takes an investment.
Yeah.
And I sometimes, one of the problems with acute services, in my view, including sort of crisis teams, etc., is that there is a role. These are professionals that are going here to fulfill this role, and that might be, they want to keep me alive. But they're a new person who just arrived. The next day will be somebody else.
Yeah.
How invested are they? And that's a difficult question even to ask. So I think that's important. It's not as simple as being there. You need to be authorized.
Yeah.
At least you are legitimate.
Yeah.
There you come in peace.
You come in peace. You come in peace. That's a beautiful thought. And I think we talk and protect a lot about avoiding a power struggle, because there's only one person who can win that power struggle. And that's a person in so much psychological pain and emotional suffering that they are thinking life is not worth living. So there's no point in getting into that power struggle, but actually getting in there proactively, seeking permission to help and support. Miguel, you have absolutely lived up to your reputation of being the poster boy for kindness and compassion. And we talk about relational safety a lot in Protect, and how you bring it to life in your simple philosophical ways in which you approach psychiatry. It's really, really refreshing. May I wish you all the best in your life endeavors, and I'm sure our paths will keep crossing. And thank you so much for giving your time so generously and sharing with our listeners your journey from Cambridge to Saigon, back to Porto, but working in Saigon, your knowledge of telehealth, and really of forming humane connections, human beings connecting with each other, walking on this road to recovery. Do you have any last thoughts that you would want to share with the listeners?
No, I think I just thank you for this opportunity. And I had a brief look at the work you're doing, which I think is extremely important. And, in a way, it's a sequence to what you had been doing in Cambridge, and for sure, I will share this content.
Thank you very much. Thank you very much, Miguel.